Hello everyone, welcome back to our channel. My name is Marco. I'm the coordinator of Game Med English by Hunt. Thanks for staying with us. Today we continue with our Meet the Expert series, and this video will be dedicated to the topic of depression. Our guest is Associate Professor of Psychiatry, Narcology and Medical Psychology Department of the Ukrainian Medical Stomatological Academy, PhD Boiko Dmytro Ivanovich. Good afternoon, Dmytro Ivanovich.
Good afternoon.
Thank you for finding some time to join us for this talk. So let's start with the basics. How can we academically define depression?
First of all, it should be noted that depression is a group of conditions that include both individual disorders and syndromes being parts of other diseases. Talking about the general features of all depressive states, we should keep in mind the triad: hypothymia, decreased mood, bradyphrenia, inhibition of intellectual activity, and hypobulia, motor and volitional inhibition. Of course, these symptoms can be more or less pronounced, but they must be present in depressive syndrome.
And what are the risk factors for the depression?
To summarize, the main risk factor for depression, like many other mental disorders, is immoderation and disproportion. And this principle can be applied to many areas of human activity: violation of sleep patterns, food intake, balanced diet, rest, etc. Naturally, one should not forget about special cases, like traumatic situations or hereditary disorders of neuromediated transmission. But generally speaking, the best prevention is adherence to a balanced, healthy lifestyle.
As it is spring now, we can't miss the topic of seasonal depression. Is there something specific about it?
Everyone has heard about the spring-autumn exacerbation of affective disorders, and it really matched their reality. In clinical practice, we noticed an increase in the number of hospitalizations in the above periods of the year. There are many articles describing the reasons for this seasonality, from the circadian biorhythms, analogous to the circadian rhythm, only the cycle takes place not a day, but in a year, to the influence of solar activity. To a greater extent, this applies to chronic mental disorders. If you have never been bothered by depression, you should not be afraid of spring. It is unlikely that it will act as a provoking factor by itself.
And of course, we talk more about mental health in the context of global pandemics. What are the features of post-Covid depression?
It is too early to speak with complete confidence about the effect of COVID-19 on the brain and the clinical manifestations of depression. Such studies are underway. But we can say with complete confidence that a pandemic is a powerful, long-term psychotraumatic factor that provokes the onset of affective disorders. Moreover, it is reflected in completely different types of personalities. Someone is oppressed by self-isolation, someone's business has suffered losses, someone has been ill and is afraid of getting sick again or infecting loved ones, etc. Let's just say that with a pandemic going on, there are more triggers for depression development.
So let's move to the way that the person can assess the depression. How can a person identify herself or himself as having a depression?
In mild, moderate, or severe typical cases of depressive episodes, the patient has low mood, a decrease in energy, and drop in activity during 2 weeks or more, reduced ability to rejoice, have fun, be interested, concentrate. Extreme fatigue is common, even after minimal effort. Sleep and appetite are usually disturbed. Self-esteem and self-confidence are almost always reduced, even in milder forms of the disease. Often there are thoughts of their own guilt and worthlessness. Low mood, which change a little from day to day, does not depend on the circumstances and can be accompanied by so-called somatic symptoms, such as loss of interest in the environment, loss of sensations that give pleasure, waking up in the morning a few hours earlier than usual, increased depression in the morning, severe psychomotor retardation, anxiety, loss of appetite, weight loss, and decreased libido.
So how to discover if another person has depression?
The criteria for detecting depression are the same as for self-diagnosis, but they are easier to notice from the outside. There are decreased mood, distinct decrease in interest or pleasure in activities usually associated with positive emotions, decreased energy and increased fatigue, as well as additional symptoms, decreased ability to concentrate and pay attention, decreased self-esteem and feelings of self-doubt, ideas of guilt and humiliation, even with mild depression, a gloomy and pessimistic vision of the future, ideas or actions regarding self-harm or suicide, disturbed sleep and appetite, early awakening and inability to fall asleep or excessive sleepiness, loss of hope for the future, periodic thoughts of death, weight loss, or controversially is gain, decreased sexual interest.
Okay, so let's move a bit to the topic of illness perception, how it is viewed by the society. Does public opinion match with the realities of diagnosis depression?
Often, society underestimates the severity of this disease, or moreover, does not perceive it as a disease at all. In everyday speech, the word depression has become a symptom of just bad mood, but this is not the case at all. If you talk about the clinical diagnosis of depression, especially in moderate or severe form, it is a serious disorder that can require long-term treatment and greatly reduce the patient's quality of life.
And how does the doctor understand that the patient simulates the illness as it becomes trendy to try to show off with that kind of mood in front of the public, for instance, in social media?
Due to the fact that every mental disorder is a difficult complex of symptoms, it is extremely difficult to simulate it. It is possible to simulate individual symptom of the disease, but the disease as a whole is almost impossible. And every single symptom is not a reason for a diagnosis. This is especially evident with depression, when the patients can only complain of a bad mood and feign a sad appearance, but forgets about the rest of the manifestations of the disease.
Okay, so now let's talk a bit more about the treatment, as it's maybe one of the most important parts here. So, can depression be treated completely without medication? If so, how?
Moreover, mild depression can go away on its own. If the effect of traumatic factor ended, the environment provided proper care and support, and most importantly, the depressive episode was mild, then it can go away by itself. Completely different question, how fast? Naturally, the help of qualified specialists will help to speed up this process many times. Depending on the severity of the symptoms, the treatment of depressive disorders can be limited only to psychotherapy or be combined with a short course of tranquilizers and antidepressants. After all, psychotherapy will not work instantly, and the patients need to be helped here and now. For this, a short course from a couple of weeks of medications is prescribed. But the main emphasis in treatment is still on psychotherapy. It is worth noting that there are many psychotherapeutic schools, but the evidence at the moment is only CBT, cognitive behavioral therapy. It is also included in the APA and NICE treatment protocols. It is very important that the treatment regimen is chosen by the specialist. There is no need to self-medicate and decide whether to take medications or not. If a psychiatrist or a psychotherapist has prescribed medication, then it is necessary.
So now let's take the opposite path. New methods of treatments are emerging in the last few years. So some of them involve the use of narcotic substances. Can you tell us a bit more about them?
In fact, the use of drugs in psychiatry is not new. They were tried to be used for treatment back in the middle of the 20th century. Then the concept of narcosynthesis and psychedelic psychotherapy appeared. During narcosynthesis, the patient is put into a narcotic trance, during which the therapist works through the patient's painful experiences. For psychedelic psychotherapy, hallucinogens such as LSD, psilocybin, DMT have been used to treat disorders ranging from neurosis to schizophrenia. But in the 1970s, US legislative ban on the use of psychedelics in psychotherapy slowed research in drug psychotherapy severely. Nowadays, such research is being actively carried out in the context of various disorders and various drugs. Everyone has definitely heard about medicinal marijuana. True, not everyone knows that the therapeutic effect is associated with cannabidiol and not with tetrahydrocannabinol. A positive effect was obtained for the treatment of both depressive conditions and PTSD. Some research results are still being implemented in practice. So, for example, in January 2020, the FDA approved the use of MDMA, known as ecstasy, to treat PTSD patients.
So this is it for today. I hope this was interesting for our participants and listeners. Please don't forget to leave the comments in the section below. I also would like to thank Dmytro Ivanovich for being with us. Thank you so much.
Thank you for the invitation. Thank you.
Yep, and also don't forget to subscribe to our YouTube channel. Leave us your feedback with likes or dislikes, and have a nice evening. See you. Bye-bye.
Bye.